Right. So I'll go ahead with my talk and this current management of ocular surface tumors. So I'll talk a little bit about the current advances in diagnosis. Of course, it's a clinical diagnosis. Tumors are staring at you, begging for a diagnosis, so you really don't have to do much. But there are situations where there might be issues with the diagnosis where you can actually do imaging. Then we'll talk about topical treatment, surgical management, radiation, and target therapy. So let's start with imaging. My slides are not moving. Okay. Are my slides moving? Yeah.
Yes, it is.
Okay, fine. All right. So so for example, if these are four patients that you have all with pigmented lesion, you go by a set of clinical criteria, that is interpalpable location, variable pigmentation, absence of corneal epithelial invasion, no episcleral fixation, no intrinsic vascularity, and microsis. But if you have any doubt at all, then you can do anterior segment OCT or UBM, where you can see small cysts, which are called microcysts, and larger coalescent cyst called macrocyst, which confirms the diagnosis. So if you have a pigmented or a non-pigmented conjunctival lesion where you want to diagnose a melanotic or a amelanotic nevus, then anterior segment OCT comes very handy. Example is this child, a teenager brought by his physician mother, where there was a fleshy pigmented, non-pigmented lesion with a feeder vessel and some amount of intrinsic deeper vessels, slight amount of encroachment on the corneal epithelium. You can't really pinpoint to the fact that it is a nevus because it's non-pigmented here. And when you do imaging, you find microcyst confirming that it is indeed a amelanotic nevus. And when the lesion transfers from nevus to melanoma, again, it carries the features. This is a patient where this part of the lesion is a nevus, and this is a newly grown component of a nevus, which is melanoma. And when you do UBM here, you find that these are microcysts that you see here, microcysts, which corresponds to the area where there is microcyst on histopathology as well. This is a nevus, and this is the watershed zone where the solid component is melanoma. So you can clinically detect if a particular nevus has transformed to a melanoma in a doubtful situation. Of course, for OSS and clinical criteria are the ones with which you diagnose it. But if you have any diagnostic dilemma at all, then you can bring in anterior segment OCT, which the features of which were very well described by Dr. Carol Karp, where you find that this is a normal epithelium, which is grayish and about 60, 70 micron thick. If the epithelium is hyperplastic, and as opposed to gray epithelium, if it is hyper-reflective, ending with a nice blunt snout. That is very characteristic of OSSN. So if you have a simulating conjunctival lesion, it may look like pterygium pinicula, etc. But if it has these features, hyperplastic, hyperreflective corneal epithelium ending with a snout, then you tend to diagnose it as OSSN. It will also tell you about the base of the lesion. Margins are something that are easy to diagnose. Like this patient has very crisp margin which is stained with rose bengal. You know, this is a margin. But what about the base itself? Slit lamp sometimes is inadequate to detect the base. So if you do anterior segment imaging, you find that this particular lesion is confined to conjunctiva, and this is bubbly tenons underneath it. So your plane of dissection can be subtenons here with a margin of safety. This is a patient where there is corneal OSS, and so until we do an imaging, we won't know whether the corneal involvement is full thickness stromal, as you see here. This is the normal corneal thickness, and this is the splayed thickened stroma. There he has full thickness corneal stromal involvement, thus needing either penetrating keratoplasty or plaque brachytherapy. For patients with anterior segment invasion, these four patients, you can never clinically say whether they have anterior segment invasion or not because you can't see behind the iris. And sometimes you cannot do gonioscopy because the lesion is right on top there. So you can do imaging to confirm whether there is anterior segment invasion already. OCT angiography can help you visualize layer by layer vascularity of the conjunctiva, and then there is this software-based remodeling where you can get 360-degree view of the conjunctival vascularity, which may help you predict early recurrences, clinically undetectable areas of early recurrence, especially if you have treated these patients conservatively without surgery. Let's go to management. The first mode of management is topical or local chemotherapy, where we can either use chemotherapeutic drugs such as mitomycin or 5-fluorouracil, or use immunotherapy, which is interferon alpha 2b. let's look at some of the indications. Before that, cost comparison. Well, 5FU is the cheapest. Mitomycin and interferon cost almost the same. Interferon has some availability issues in some parts of the country. The major difference is that mitomycin works definitely better, it works faster and better, but it has a lot of ocular surface issues, ocular surface complications. So in terms of tolerance, mitomycin is the worst. In, in terms of tolerance, interferon is the best. It has very mild effect on the ocular surface, so patients tolerate it very well, but interferon is very slow to work. So somewhere in between is 5-fluorouracil, which is moderately effective and moderately toxic. So if you have a choice between 5-FU and mitomycin, you can choose 5-fluorouracil in a patient who is not tolerant to mitomycin. Or if you think the patient is going to be compliant for a prolonged haul, that is 3 to 4 months it takes for interferon to work, then interferon is good. So either which way, these are the three drugs which are classic, time tested and effective. So when you do these treatments, there are three ways you can use them. One is for complete tumor control, which is called immunotherapy or chemotherapy. When you want to simply reduce the size of the lesion and the residual part of the lesion you want to take care of by surgery, that is called immunoreduction or chemoreduction. When you want to enhance the immune system so that the patient does not have multiple episodes of local tumor recurrence, that's called immunomodulation. There you give once a day dose of interferon for a very long time, specifically in patients who have a high chance of local tumor recurrence, such as xeroderma pigmentosum patients or patients with HIV seropositivity or organ transplant associated immunosuppression. So these are the three ways of giving treatment. Let's look at some of the patients for indications for immunotherapy. If you have a small lesion of this sort, patient who has a lesion which is say 1 or 2 clock hours, very small lesion where you simply don't want to do surgery, and if you have time for 6 to 8 weeks, you can treat them with topical therapy and it goes away. One more example of a smaller lesion which is about 1.5 clock hours, gone away, leaving a residual actinic keratosis, which was the precursor of the lesion. Of course, that doesn't change, and the rest of the lesion has gone away. So these are all patients who have been treated with topical therapy, very small lesions, 1 to 2 clock hours, flattish, and they do well. One more example of a small lesion gone away with topical therapy. That's one indication, small lesions. Second, and the most important indication is when there is corneal epithelial invasion. This is a very nice picture where the cornea specialist has done a biopsy here, after which he has sent the patient over for consultation. Now, rest of the tumor has been treated with topical therapy. This is after a few days after starting topical therapy. This is after a few weeks, and this is after a few years. So what you notice is that there is subtle corneal scar exactly in the area where biopsy has been performed. So what it means is that if you were to try to do excision in this patient primarily, you may have possibly caused some corneal scar in the pupillary axis, thus precluding 20/20 and 6 vision. So in a patient who has corneal involvement of OSSN, where the epithelium is involved, it's not really stromal disease, and it involves a visual axis like this. So very ideal indication for topical therapy. This is an example of a patient where penetrating keratoplasty has been done. This is a patient with xeroderma pigmentosum where, because of corneal scar, keratoplasty has been done. And this is a precious graft for the patient. It is a failed graft, after which a regraft has been done. And unluckily, at the graft host junction, the patient has developed a OSSN, which xeroderma pigmentosum patients are anyway prone to develop. Now, this patient, if you were to do surgery, you may induce graft rejection or graft failure. So short of that, when you treat them with topical therapy, you can see that the lesion completely gone. So this is one indication. Difficult situations where you cannot do surgery, where you can rely on topical therapy. The third indication is lesion which are involving more than 6 clock hours of the limbus. Well, these can be excised, especially with simple limbal epithelial transplantation that you can combine it with. But generally, if a patient has more than 6 clock hours of limbal involvement, then there is a slightly higher chance of limbal stem cell deficiency and conjunctivalization of the cornea. To avoid that, for a flatter lesion like this, you can definitely use topical therapy, and that's scarless healing. There's hardly any scar in that area, and the limbal integrity is maintained following regression. or a diffuse lesion like this. Diffuse is when the thickness of the lesion is less than 20% of the basal diameter of the lesion, or if the lesion involves more than 6 clock hours of the ocular surface. This patient has a larger lesion involving about 7 to 8 clock hours of ocular surface, and interferon works very well in flat lesions. Like if a patient has a flat lesion, interferon works very well. If a patient has a large elevated lesion, then interferon may not work so well. Mitomycin may work in giant nodular lesions. One more example of a diffuse tumor, but this patient unfortunately has almost the entire ocular surface involved by the tumor. The bulbar conjunctiva, palpebral conjunctiva, this is a clear-cut case for orbital exentration. Now here in this patient, with the other eye being non-seeing in this patient, we had to do something more conservative. And after doing map biopsy, confirming the extent of the tumor, we started this patient on injection interferon, 3 million international units, received 6 injections followed by topical therapy, and he's doing pretty well after several years. So all of them do not respond so well. It's like a 50-50 chance. In such situations, injection interferon may work in half the patients, and in half the patients, you may still have to do extensive surgery or orbital exentration. HIV positive patient with palpebral conjunctival, pharyngeal, and bulbar conjunctival involvement, again responding very well to injection interferon. So injection interferon is used in 2 sets of patients. One, if a patient is non-compliant to therapy, or if you assess the patient and appears to be non-compliant to therapy, you can give injection 3 weekly. Or if a patient has a larger diffuse lesion, then injections work much better than topical medication. Next issue is about immunoreduction. For a patient who has a slightly larger lesion, where you can excise, of course, but with a lot of ocular surface reconstruction, if you want to reduce it in size, then you can use topical therapy. So this larger lesion has reduced to this smaller lesion on topical therapy. So how do you explain that? For example, if this is the limbus and this is the tumor, the epicenter of the tumor, and this is the complete extent of the tumor. Let's assume that this was the epicenter of the tumor. That generally happens to be invasive squamous cell carcinoma. Topical therapy does not work well on invasive squamous cell carcinoma, but surrounding it would be zones of carcinoma in situ, mild, moderate, and severe dysplasia. Then topical therapy takes care of all those areas, and what is left is just this invasive squamous cell carcinoma component for you to excise. So lesson here is that topical therapy works very well on dysplasia and carcinoma in situ, leaving part of the invasive squamous cell carcinoma to be taken care of by surgery. So your extent of surgery is much less. Immunomodulation is for patients, as I said, xeroderma pigmentosa and HIV patients who tend to recur, have multifocality. There you want to modulate their ocular surface immunity by using topical therapy. It is said that you have to differentiate from HPV-mediated OSSN versus actinic damage-mediated OSSN. We cannot clinically, and there are no good tools currently, even PCR-based diagnostics, to say that a particular patient has HPV-mediated OSSN or it is actinic keratosis mediated or actinic damage mediated OSSN. But in patients with immunocompromised status, it is said to be HPV, human papillomavirus mediated infection, whereas xeroderma pigmentosa patients, you can either have HPV mediated or actinic damage mediated. So you really don't know, but in both the situations, somehow interferon used as an immunomodulator on ocular surface on once-a-day dose seems to be working well. So, the differences between topical advantages and disadvantages are that topical therapy is definitely non-invasive, apparently reduces the incidence of limbal stem cell deficiency, produces scarless healing, but it is expensive in the long run. If you have to use interferon for 6 months, it's almost more than the cost of one-time surgery. And the patient has to be very compliant, and you'll never have histopathology evidence. So these are the disadvantages. Now, topical therapy, to repeat what I said, corneal OSSN, diffuse placoid lesion, compliant patients accessible for follow-up, adjuvant therapy for edge involvement, etc., and for chemoreduction is useful. Whereas for invasive squamous cell carcinoma, or when patients have lesions where you're unsure of the depth despite imaging, where there is a localized nodular tumor, intolerance to topical therapy, and poor compliance anticipated, then you do surgery. Now, when you talk about surgery, you talk about excision with tumor-free margins. Now, how do you determine the tumor-free margin? But a very good slit lamp evaluation associated with staining, either with rose bengal or any other vital stain, specifically for squamous neoplasias. Staining doesn't work well for pigmented lesions. So staining is important for squamous neoplasias, with which you know subclinical margins as well, and beyond that 4 millimeter margin. Then for the corneal epithelial component, use what is called alcohol-assisted keratoepitheliectomy. Lamellar keratectomy, generally you don't perform, rather do plaque brachytherapy for the residual, unless you know that it is very superficially involving the corneal stroma and you can get away with a superficial keratectomy. Lamellar sclerectomy can be performed if sclera is involved in a localized fashion. Cryotherapy to the resection edge is mandatory. Every patient who undergoes excision has to undergo cryotherapy to the conjunctival resection edge, not to the corneal resection edge. And base cryotherapy is only when during surgery you discover that 1 or 2 clock hours of the limbus may be slightly deeper involved. So pending pathology report, it's a good idea to cryo that particular part of the base. These are the kind of drawings that you want to draw for complex lesions, where you map out every part of the lesion, have a surgical plan, and take it to the OT. Let me show you a video clip of a simple excision of a small conjunctival ocular surface squamous neoplasia. Small or big, the principles remain the same. You identify the margin, clinically clear margin. Beyond that, you mark 4 millimeter, and then you incise the edge. Never hold the tumor itself, always hold normal conjunctiva around it, and try to be as little manipulative during surgery as possible. We're using RF electrode, which is good, but you can also use scissors and blade. That's the dissection of the base under visualization. Then as you reach the limbus, if there are exuberant blood vessels there, you can cauterize them. Dry the cornea and apply absolute alcohol for about 15, 20, 30 seconds till the corneal epithelium turns subtle gray. Then the epithelium loosens, you know that, and you simply have to scroll the corneal epithelium to reach the limbus from the corneal side. You have already reached the limbus from the conjunctival side. This rolls off the Bowman's membrane very easily without damaging the Bowman's membrane itself, which is a very good barrier for tumor getting into the stroma. So you have to be very gentle and scroll it off till we reach the limbus from the corneal side. Then you do a superficial lumpectomy, all under visualization. Some surgeons believe in dry technique, but I believe nothing is dry, because if you don't squirt saline, then blood will make it wet anyway, and you won't even be able to see the base. So I'd rather have a wet field where I can visualize, and that's the reverse cryo, where I drape the conjunctiva on top of a 3 millimeter large cryo probe and cryo the entire conjunctival edge twice over. This is called double freeze thaw cryotherapy with spontaneous thawing all around, done twice over. This gives you additional 3 to 4 millimeter clearance over the margins that you already taken. Since during surgery we thought that the limbus was slightly deeply involved in this particular claw cover, we are doing base cryotherapy also, pending histopathology, of course. Pathologists will also confirm the claw cover where the base may be positive. So once you're done all this, you have to repair the conjunctiva. You can use a conjunctival autograft or simply put in an amniotic membrane, either sutured or glued. It's your choice. Glued is always good because patients are very tolerant to glue rather than to sutures. Either which way, anyway, conjunctiva heals very well, and by 6 weeks, they're all good to go. This is an example of a larger lesion treated with excision. Now, excision can also be based on intraoperative OCT, which is supposed to be very useful, but the accuracy of intraorbital OCT in terms of image resolution is not so good. So finally, you have to depend a lot on your preoperative OCT and also your intraoperative clinical observation to determine the base, and finally wait for the pathologist to tell you that it's all clear. Now, what is the role of primary simple limbal epithelial transplantation? We have been doing it more often than earlier now, especially if there is an indication. So my indication is that if there is extensive limbal involvement and or you have done radiotherapy, plaque brachytherapy, then you using primary simple limbal epithelial transplantation may help have a better ocular surface and have patient to have better visual acuity, because the chance of limbal stem cell deficiency and conjunctivalization of the cornea and need for secondary surgery for that purpose will be much less. Surgery does remain an excellent option. So what are the indications for adjuvant therapy following surgery? This is the protocol that we have. If the resection edge is positive on histopathology and it has only dysplasia or carcinoma in situ, and you've already done cryotherapy, then you do nothing, you observe. That's the advantage of cryotherapy. Resection edges can come positive, unfortunately. And if you're already done cryotherapy, you have to do nothing. If you have not done cryotherapy, then you can do topical chemotherapy or immunotherapy because carcinoma in situ and dysplasia respond to topical therapy. If resection edge is positive and the pathologist tells you that there is invasive squamous cell carcinoma, then medico-legally you're bound to re-excise because we know that invasive squamous cell carcinoma does not respond to topical therapy. Or if it's a melanoma that you're dealing with. If the resection base is positive and the pathologist is able to tell you that, okay, 1 clock hour is involved and that's 4 o'clock, then you can definitely go ahead and do cryotherapy. If the resection base is positive, but the pathologist is not able to tell you what is the location of base positivity, or if it is diffuse, then you can't go ahead and do scleral excision, but you can easily do plaque brachytherapy. Then immunomodulation we already talked. That is the indication for adjuvant therapy. Now, there are certain difficult sets of patients which are beyond surgery, like patients who have scleral invasion upfront. There we do plaque brachytherapy. Plaque can be done in two ways. One is secondary plaque brachytherapy, where you excise the tumor in flush with the sclera or take about 10-20% of scleral thickness, wait for the pathology, histopathology to confirm the base involvement and the diagnosis, and wait for the ocular surface to resurface 3 to 4 weeks. You would already put in an AMG and then do cryotherapy, then do plaque brachytherapy. That is called secondary plaque brachytherapy guided by histopathology. Like all these patients have undergone secondary plaque brachytherapy and they're doing fine. We already know that they have scleral involvement, but you still wait for the pathologist to confirm because sometimes it may not be OSS and it may be mucoepidermoid variant of OSS and things like that. So it's one way of doing it. But the current trend is to do what is called primary plaque brachytherapy. Now, primary plaque brachytherapy can be done in two ways. One is that you don't excise the tumor at all, place it right on top of the tumor, where the cornea is already melted, and if you were to do surgery, tectonic integrity may be lost. You do a small biopsy, confirm the diagnosis, and you can place the plaque right on top of the tumor. Or you can excise it and without waiting for pathology, just based on your OCT information that it is a stromal involvement or scleral involvement, then you can place the plaque. That is also called primary plaque brachytherapy. In any case, plaque is very highly effective with eye salvage rates of over 90%. So some examples of whether we can save advanced cases. This patient, a young individual with reasonable vision earlier, multiple excisions, and has intraocular extension. You can see that he has choroidal invasion already. So earlier we would enucleate such patients. Now that's the retinal detachment that he has. Here because the patient was not keen on enucleation at all, we chose stereotactic radiation, and you can see that he has responded. That's the MRI scan, and that's the field of radiation that we chose to give, and see how nicely he has responded. His retinal detachment is gone, his scleral invasion is gone, his choroidal invasion is gone. So stereotactic radiation can help. This patient was given chemoradiation, actually concurrent 5-fluorouracil and radiation, worked very beautifully for him. And even on UBM, you can see that it's all gone. So this is one situation where we could salvage. Another situation where we could salvage is when the extraocular muscles are involved by the tumor. So if the extraocular muscle is involved, you can do plaque brachytherapy on top of it. Like this patient with melanoma with multiple excisions elsewhere. Let me see if this video plays. Yeah. Right. So this is a patient where there is extraocular muscle involvement also. I hope that part is captured in the clip. Anyway, so we are excising the lesion. This has PAM component also. We excise the part of the melanoma and PAM. The muscle has been hooked and tumor has been removed. And you can see that the muscle which was involved is also removed. So that information we get from the MRI. Phonesis are checked. That is alcohol-assisted keratoepithelectomy and removal of pigmented areas. The muzzle is put back in its position after the stump has been excised, and the plaque is placed on the bed of the tumor, and then we rotate it to cover the insertion of the extraocular muscle. that is the rotation on subsequent occasion, say within 18 or 24 hours, as soon as the dosimetry uh, related exposure time is over. Then you cryo the base and cover the ocular surface with amniotic membrane. So that was an extensive surgery where plaque was rotated 3 times, and symblepharon ring would be mandatory, and a tarsorrhaphy is mandatory in such patients. But the gratifying fact is that they do very well. You don't have to do exentration in diffuse melanoma. You can actually treat them with surgery. The same patient after several months doing very well without any trace of recurrence. Last bit is about some newer advances such as vaporization. Like patients who have lymphangioma, you can give bleomycin, but anterior lesions, bleomycin is slightly tricky because you may have corneal epithelial toxicity. You can simply vaporize them using RF electrode. Works better than carbon dioxide laser. Extensive lymphangioma of the ocular surface, again vaporized with multiple sessions of RF, and this conjunctival scar, of course, can be excised and ocular surface resurfaced. Last bit is about target therapy for ocular surface tumors. This is a patient where there is a lymphoproliferative lesion, lymphoma, and what we can excise is the anterior component of it. The lesion is gone along the eyeball between the SRLPS complex there, hugging the eyeball. So that part is difficult to excise. Only option is after excision of the anterior component to give radiation to the residual. Well, if you don't want to give radiation and you know that it is mild lymphoma on histopathology and you want to be minimally invasive, then you can give rituximab injection. Perilesional rituximab 5 milligram per ml is the dose that is used, and Mont lymphoma responds very well to 3 weekly injections of rituximab. Now, for melanoma specifically, mutational spectrum has all been worked out, and you have specific target therapy for each of these mutations. And reports have started appearing in the literature about the use of various target therapy agents. This was a patient when nivolumab was given for his lymph node metastasis, whereas he also has conjunctival tumor recurrence. And after 3 months, his conjunctival tumor recurrence has disappeared. So this could come as a primary therapy. Of course, it's expensive currently, at least in patients where you want to avoid drastic measures such as orbital excentrations. So I would say that the management of ocular surface neoplasia is extremely simple. It is strategy that is more important than the technique. Technique is very, very simple. You have to apply a particular therapeutic strategy and a protocol to a given patient or customize it, and then do surgery based on that protocol or apply all therapeutic modalities based on that protocol. Imaging, target therapy, and innovative use of plaque brachytherapy always help, and we have definitely improved the outcome in such patients by using a combination of treatment rather than relying on just one. Thank you so much.